Welcome back, everyone. We are going to head right into the second panel of the third annual virtual TSM conference, Redefining Recovery. I'm Jenny Williamson, Executive Director at the C3 Foundation, and I'm so glad that you're here with us today. This conference is available to view and to participate in for free, thanks to our two co-headline sponsors, RIA Health and Work It Health. If you'd like to support the work of the C3 Foundation, there's a donation link in our profile, and we have a timer that will also drop a donation link into the chat during the broadcast. Also, if you're on Twitter, please feel free to live tweet our conference with the hashtags Redefining Recovery and Options Save Lives. It's a great way to amplify the impact and reach of our conference. Our next presentation comes from Crystal Fedeli, who will speak about the need for substance use disorder treatment reform through the lens of child welfare. So Crystal is the founder and executive director of A Way is Made. She's currently completing her Master of Social Work. She holds a Master of Arts in Social Research and Analysis, Master of Arts in Child Advocacy and Policy with a Child Public Welfare concentration, a Graduate Certificate in Data Collection and Management, Paralegal Certificate, Bachelor of Arts in English, and an Associate of Arts in English. She sits on the Monarch Housing Homeless Prevention Advisory Board, and she is a member of the New Jersey Coalition to Help End Homelessness and the Anti-Poverty Network of New Jersey. She also holds a committee person position and is the secretary of her township's political committee. She's a member of her county's political committee, and she is a 2022 mayoral candidate for her town. Crystal loves to hang out with her husband, 1- and 4-year-old, and their dog. Crystal, welcome to our conference. How are you today?
Good. Thank you for having me.
So I'm going to go ahead and switch into my Zoom and go ahead and hide my video now. I'll let you pull up your slides, and I will pop back in when it's time for Q&A.
All right, sounds good. Can you see my screen? Okay, you can see my PowerPoint. Okay. Okay, thank you. Sorry. Hi, everybody. My name is Crystal Fedeli, and this is my presentation today. I'm going to talk about the need for substance use disorder treatment reform in the United States, and it's as a matter of child welfare. All right, so I just want to start with my story. So my name is Crystal Fedeli. I am a survivor of alcohol use disorder. I suffered for 8 long years in our current treatment system's approach to alcohol use disorder until I became aware of the Sinclair method in the late summer of 2019, thanks to Claudia Christian's TED Talk. And I was then able to access the treatment in the fall of 2019, thanks to the C3 Foundation's Resource Hub. What I could not do in 8 long years, I was able to accomplish in 2 to 3 months on the Sinclair method, recovering from alcohol use disorder. I was diagnosed with alcohol use disorder in the fall of 2015, and I finally had a diagnosed medical condition to explain why I was suffering so terribly from alcohol for the 5 years prior. But the only option for treatment that was offered to me was the intensive outpatient program that I was in at the time, was to quit drinking by sheer willpower. I was drug tested every day of treatment, and it was actually never explained to me that I was supposed to completely abstain from alcohol. I learned this when I mentioned in group therapy that I had a glass of wine the evening before and I was only able to have one glass. I was so happy and I wanted to share this accomplishment with my fellow survivors, to only be scolded shortly after by the staff that worked there and was threatened to be discharged from the program. To know I was receiving life-saving treatment for my other, at the time, newly diagnosed conditions, postpartum depression and major depressive disorder. The two conditions were a direct result of the early chronic childhood trauma I suffered. So traumatic that Child Protective Services in my state had to get involved, and there was a removal of custody eventually. Although I was able to begin my journey of healing from PTSD and major depressive disorder at this IOP, I still suffered terribly from alcohol use disorder for years to come. It was not until the late summer of 2019 when I saw Claudia Christian's TED Talk that I learned about the Sinclair method. At the time, I thought taking a pill to cure my alcohol use disorder, something I severely suffered for so long, was too good to be true. And I discounted the idea. But then I became so desperate that I thought, what the heck, at least I could give it a try. And little did I know that gaining access to this treatment was next to impossible in our current treatment system, though. At the time, I was a fairly new single mother of a 1.5-year-old, and we were not even able to afford our basic necessities. I had no support from her biological father, and I have no family in my life due to the traumatic childhood. I was a single mother I was a single mother as a single mother could be. So at the time, we had New Jersey Medicaid for health insurance, and not many providers accepted our health insurance. I contacted our primary care practice that took our health insurance to only be told by the doctor, I just don't think you need this naltrexone. The head doctor of the practice then came in and told me that she thought I was trying to go through the back door to get treatment, after they presented as the only option was for me to attend their hospital system's behavioral health clinic, where I would be forced to meet with a therapist who would decide if it was even necessary for me to see a psychiatrist who could prescribe me medication. I had explained that I already had a therapist for 5 years. They refused to prescribe me the naltrexone. I then made an appointment with another doctor who had been very helpful in the past and prescribed me the necessary medication when I suffered from postpartum depression. After I explained to her what TSM was, she said, "You cannot be the doctor and treat yourself." And she refused to prescribe me the naltrexone. Another doctor's office that took my Medicaid that I made an appointment with refused me again and again for the third time. Each doctor sent me away untreated with my small baby. I was devastated and I felt terrible that my child had me for a mother. I believed at the time that she deserved much better because I was really suffering from my AUD. One day I was so desperate that I took money from my rent money to pay for the $70 that a telehealth provider I found through the C3 Foundation's Resource Hub. And within 2 minutes, I had access to my medication, finally, even if I was not able to pay my rent in full. Although I did not have the support of a therapist or coach, I was on my own. Then when I was able to acquire full-time employment with the state of New Jersey, ironically with the Office of the Public Defender in the drug court unit handling drug court expungements for the entire state of New Jersey, I was able to acquire health insurance after 3 months of employment, and then I was able to enroll in RIA Health's program. Sadly, short after the 2-month mark, I had one more night where I drank too much. My therapist at the time, who I had been a client of for 5 years, said that she did not agree with my way of recovering from alcohol use disorder, and she explained that she was not a good fit as a therapist for me anymore. To note, I had no more episodes out of over drinking after she discharged me as a client. Then, by the grace of God, I was able to find a primary care provider after I completed the RIA Health program, who actually took my insurance, so I didn't have to pay out of pocket, and who was willing to prescribe me my naltrexone. However, she left the practice a little over a year after that, and I was unable to find a provider who would prescribe my naltrexone who took my health insurance. Unfortunately, I spiraled back into suffering from alcohol use disorder, just as I was suffering before I ever found the Sinclair method. I found a provider who was only willing to prescribe naltrexone if I took it every day. I was suffering so much that I thought it would not harm to take naltrexone every day, as that way of taking naltrexone is proven to reduce cravings. So for 3 months, I was feeling amazing. I had no cravings or obsessive thoughts. He's upstairs, babe. You want to go upstairs? And really no desire to overthink alcohol. But shortly thereafter, I was suffering from my alcohol use disorder again, just as if before I found the Sinclair method. Since I had an abundance of a supply of naltrexone, I eventually began taking naltrexone through the modality that the Sinclair method follows on my own with no support of a coach, therapist, or a doctor. And I became better within a month. I am completely fine again, and I will never go off the Sinclair method. And I pray God provides a way for me to always access my medication, even if I don't have the support of a coach, therapist, or doctor. And before I get to the actual research part of my presentation, I just want to share that I'm a Christian, and I believe in God and that Jesus still heals today. I believe in miracles, but I also believe that God is for miracles that happen through a practical process. I prayed in my early 20s to be healed of the alcohol use disorder I was suffering from. I always just knew in my spirit that even in my early 20s, that giving up alcohol for the rest of my life was not the answer. I just knew. I knew that one day I would be able to just have a glass of wine if I wanted to, even though at the time it seemed like an impossible reality. So God finally led me to watch Claudia Christian's TED Talk and the C3 Foundation to finally give me the answer of my prayer in my early 20s. I thank God that He kept me and others safe throughout this process, and that what I could not heal from in 8 long years, that I was able to heal within a very short time. And now that I can relate to others who are suffering with a substance use disorder, I can sit with them and not judge them, but explain that it's the treatment system at large that deserves the blame instead, not the person suffering. More, I can advocate for those who suffer. I began a coaching business called Fedeli Coaching, providing coaching for alcohol use disorder using the Sinclair method. I currently give 5 free coaching sessions away a month to those financially vulnerable. I wish I could give more, but I clearly volunteer in many areas. And then I've created a nonprofit, finally officially filed, and there will be a branch of that will give coaching and just, expand this whole, nonprofit to help those financially vulnerable so they can gain access to evidence-based treatments for substance use disorder at large. All right. And so today I'm healed. I'm a happy wife, and I'm a mother of a 1- and 4-year-old. You just saw the 4-year-old, and a dog mom. And I, as Jenny shared, I hold, 2 master's degrees. I'm finishing a 3rd, and I want to go to law school, and then I'm going to hang my hat of higher education. I'm a small business owner of a professional organizing and cleaning business, my coaching business. I'm a nonprofit starter. I'm a political candidate. And there's just always hope and healing because God always makes a way out of no way. Just keep hanging on and do not let go, because God will complete the work that He began. So now to my research portion. So the failure of our current system, an overview of the statistics, the failure of our system at large. Only 1 out of 10 people will seek treatment for substance use disorder, according to the United States Department of Health and Human Services. That is 10% of people who suffer from substance use disorder will seek treatment, meaning 90% do not even seek treatment. It takes a person who suffers from a substance use disorder on average 10 years before they seek treatment. And only 1% of people who suffer from a substance use disorder receive any formal treatment. So out of 10% of people who wait on average 10 years to seek treatment for substance use disorder, roughly only 1% actually receive formal treatment. This is according to our United States government statistics. These statistics prove that our substance use disorder treatment system is failing those who suffer from substance use disorder. And I would point us to how are we treating it at large if that's the outcome that we're getting. So the failure of the child welfare system behind all these people who are suffering from substance use disorder, there are so many children who are suffering from having a parent who is not able to heal from something that we know now through evidence-based medication-assisted treatments is so easy to heal from. So a major reason why families are reported to and are involved with the child protective system is due to parents suffering from substance use disorder. Roughly 2/3 of children in protective cases involve parents with substance use disorder, and nearly 79% of children in out-of-home placement is due to parental substance abuse. In 2017, nearly 1 out of 3 families reported to child protective agencies and where children were removed and placed in out-of-home placement was due to parents suffering from substance use disorder. The federal data indicates that parent drug abuse accounts for child removals over all reasons. According to parental substance use disorder in child protective cases is a pervasive problem. And according to Lloyd and Brooke, in an article that they wrote in 2019, child welfare's approach to addressing parental substance use disorder impacts hundreds of thousands of children each year. And these statistics keep increasing over time as time progresses. Families reported to and involved with the child protective system due to parental substance use disorder has increased between 2010 and 2019 from 18 to 31%. So in addition, child removals due to parental drug abuse increased by 60% from 2007 to 2017. So if we're getting such terrible outcomes, right, in the system at large and in the child welfare system, I think that we have to look at our current treatment system. What are we doing? Why is it failing so poorly? So the current treatment system, we have to look at our current treatment system. Why our current treatment system is what it is today and look at the history. So in the 1970s and the 1980s, it was a time when challenges to conventional wisdom surrounding alcohol use disorder treatment was looked at. The only option for treatment was abstinence via intensive treatment, and attendance on a regular basis to 12-step meetings was the only course of treatment that was occurring. There was such a strong belief in this approach to treat alcohol use disorder. When advances were made in alcohol use disorder treatment, there was a hostile response. So when changes were made, there was a hostile response. However, the advance in alcohol use disorder treatment was made that the role of alcohol use disorder treatment needs to be one that focuses on relapse prevention, whether through controlled drinking or abstinence. Controlled drinking is still ignored or ridiculed as at some treatment facilities today. Medication-assisted treatment seems to be accepted, but not widely adopted. The 3 approaches to treatment. There are presently 3 major approaches to treatment of alcohol use disorder, no matter how severe the condition is: the use of mutual support groups, behavioral therapy, and medication-assisted treatment. And those are fine, but what is the major theory behind the current approaches to treatment? A practice-based approach that requires abstinence. So there are 2 approaches that affect substance use disorder treatment policy system-wide: a practice-based approach versus an evidence-based approach. We will talk about an evidence-based approach more later. So to differentiate between the 2 approaches, approaching substance use disorder with a practice-based approach is using current practice, policy, and professionals' opinions and experience to inform policy. Approaching substance use disorder with an evidence-based approach, however, uses the scientific basis to inform policy. Currently, much of the approach towards substance use disorder treatment is not evidence-based, but is instead practice-based. That is, the approach to substance use disorder is currently based on current practice, policy, professional opinions, and experiences versus being approached on a scientific basis. That's a problem because professionals are wrong all the time. Experts are wrong all the time. Many experts disagree, right? We need to really look at what the evidence tells us, or what the science tells us, which is conducted through clinical trials and studies, et cetera, right? So the result of our system using a practice-based approach is that the traditional and still largely present route of treatment has been one where the goal is abstinence. That is the main opinion among professionals, that abstinence needs to be the goal. An abstinence-based approach requires that those who suffer from alcohol use disorder completely cease the use of alcohol for the rest of their lives. This goal of treatment is still pushed as the only route of treatment, despite the data proving its failures that I opened with when I opened with my research of this presentation, covered in part 1. A study conducted by Maisel seemed to come across as having a bias where the goal of alcohol use disorder treatment is abstinence, despite their study seeing the high efficacy rates through the use of medication-assisted treatment. And they're even mentioning the Sinclair method. According to the NIAAA, the most common source of help sought to treat alcohol use disorder in the United States were mutual self-help groups, despite advances in medications and behavioral therapies to treat alcohol use disorder. Alcoholics Anonymous has the largest following. So even despite these researchers seeing that the Sinclair method and medication-assisted treatment have, the science proves that it has much higher success rates, they still let their bias take over and think that, and still have a bias, no, we need to do abstinence. So even in the face of the evidence, people's biases, because of a practice-based approach, takes over as what is pursued. So that is the danger of approaching this with a practice-based approach versus an evidence-based approach. So barriers to treatment due to practice-based approach that requires abstinence, the patient and the practitioner side. On the patient side, there are reasons why people do not seek treatment. According to the United States Department of Health and Human Services, 11% say that there is no program that has the type of treatment they desire. 12.6% indicate that they do not know where to go to receive treatment. 40.7% are not ready to stop. And the United States Department of Health and Human Services indicates that the most common reason for someone to not seek treatment is because they are not aware they have a disorder that they need treatment for. And the NIAA indicates the primary reason a person does not seek treatment is due to how alcohol use disorder is stigmatized in society. 12.6% say that they may have negative effects on their appointment. 8.3% say seeking treatment may cause neighbors or their community to have a negative opinion of them. Wanklin, in a paper he wrote in 2016, also shares the idea that patients may not seek treatment due to the perception that others will be disappointed in them. On the practitioner side, the opinions and perceptions, as I covered a few minutes before, of patients, fear is not limited to their neighbors and communities. Patients are affected by social exclusion by physicians as well. Many physicians have a lack of understanding of alcohol use disorder as a medical disorder that is treatable, despite the American Medical Association affirming that alcohol use disorder is a medical disorder. Therapists need to be better educated, as therapists' beliefs may have a great impact on client recovery as well. Now we should get into the approach of the child welfare system. How do they currently approach it? So current policy is that the child welfare system approaches parents who suffer from substance use disorder in a practice-based approach. Based on current practice policy, professionals' opinions, and experiences, again. The result is that the current child welfare system's policy approach is punitive. Many child welfare agencies see parents who suffer from substance use disorder as being responsible for abuse and/or neglect, and as failing to protect their children from risk of harm, and as failing to provide for the basic needs of their children. Due to this perspective, child welfare agencies treat parents who suffer from substance use disorder with a policy that is based on compliance or a compliance-based approach. So examples of policies that are punitive and compliance-based are how reunification is often compliance-based that provides little flexibility. This compliance-based policy often uses drug testing to monitor abstinence and requires completion of a substance abuse treatment. Further, another policy that is compliance-based and punitive is the Adoption and the Safe Families Act, ASFA, that establishes a timeline that does not allow parents who suffer from substance use disorder enough time to achieve and demonstrate sobriety long enough to appease the courts and the child welfare system. So basically, we have a failing system that clearly does not have good outcomes. As I outlined in the beginning, we have a 1% success rate, but yet that's the standard for parents to be able to get their children back. Now, of course, children deserve to be safe, right? And not abused, not neglected, of course, right? So that is why I am calling for us to reform the way we approach substance use disorder, not only at large, but especially in the child welfare system, because it's hurting families and children, and we're punishing parents, and it's not their fault. It's actually our fault who are in the system. So the ASFA stands in stark contrast to the road to recovery for those who suffer from substance use disorder that is unpredictable and long, right? I mean, that's what it is in our current treatment system, not what I'm advocating for and we at this conference are advocating for. The child welfare system is set up to place blame on parents, and but we need to place blame on society's failings. If the child welfare system created policy that worked on behalf of the parents suffering from substance use disorder, this system would thereby be working on behalf of the children. So next we'll get into child protective services, case management of parents suffering from substance use disorder. Regardless, an evidence-based approach is necessary. Regardless of the vast number of continuing growth of the amount of children who suffer due to parents who suffer from substance use disorder, the subject remains to be understudied. Lloyd and Brooke differentiate approaching parental substance use disorder from a practice-based approach to an evidence-based approach. Currently, much of the approach to substance use disorder for parents in the child protection system, as we said, is not evidence-based, it's practice-based. Currently, the child welfare approach to parents who suffer is punitive. So we need to reform the way we approach that in the child welfare system. A lot of professionals in the child welfare system lack expertise regarding substance use disorder treatment. And that is a barrier to workers working with their families. And so they need to gain more education. And so we need to create a partnership with them so we can really educate workers on how substance use disorder really works and what really is the best treatment for substance use disorder. All right, next we're going to talk about substance use disorder according to the science. So I've laid out the failure of our system. I've laid out why our system is failing, what approach our system is using at large and in the child welfare system. And now I'm going to say, in contrast, what does the actual science say? You all know it because you've been attending this conference, but let's go over it just in case. All right, so root causes according to science. So let's start with the definition of alcohol use disorder. So it's considered a medical condition. That is important for us to pinpoint, right? And the NIAAA, our government, is even recognizing that it is a medical condition. It exists on a spectrum, mild to moderate to severe. And someone who has an inability to stop or control their use of alcohol, who has consequences to their work life, to their social life, to their personal life, etc., is someone who suffers from alcohol use disorder. Now, what are the root causes? This is important because whatever we misdiagnose, we mistreat. And so we need to diagnose this correctly. What is causing this? There may be several causes of alcohol use disorder: genetics, family history, suffering from mental health conditions, and having a history of trauma can also increase someone's risk of suffering from alcohol use disorder. Someone can also increase their risk by their lifestyle choices, such as drinking at an early age. How much, how often, how quickly someone consumes alcohol. That is alcohol misuse. That can increase somebody's risk of suffering from alcohol use disorder. An evidence-based and highly effective way to treat alcohol use disorder. The Sinclair method, a medication-assisted treatment, right? This is underutilized yet effective, but still yet recommended by science. Less than 4% of people who suffer from alcohol use disorder are prescribed medication to treat their diagnosis, despite there being medications that are approved by the FDA to treat AUD. Despite there are evidence-based treatments that exist for those who suffer from alcohol use disorder, no matter how severe their condition is, that includes medication as well as behavioral therapy and mutual self-help groups. The United States government has been recommending the treating alcohol use disorder with naltrexone since the 1990s, according to the NIAAA. And as Maisel mentions in their 2012 paper, and they mentioned the Sinclair method and Dr. David Sinclair, one treatment for alcohol use disorder that, as we know, has a 78% success rate, the Sinclair method. They mention it in their paper. So to note, all clinical trials found, as we know, that roughly 10% of those were non-medication compliant, that there were those who did not respond well to the medication that's used in the Sinclair method. However, there are other medications that those patients can work with their doctor to have prescribed to them, according to one of our speakers, Dr. Escapa, right? That's in his book. So how it works. We all know how the Sinclair method works, but I'll just go through it really quickly. So somebody who suffers from alcohol use disorder takes 50 milligrams of medication, the medication naltrexone, at least 1 hour before they want to drink. And I'm citing Dr. Escapa's book here. Naltrexone is an opiate blocker. So someone who suffers from alcohol use disorder has a brain that releases more endorphins as compared to someone who does not suffer from alcohol use disorder. And then when the receptors receive the message, the person who suffers from alcohol use disorder's brain learns that they need alcohol to survive. The naltrexone, if taken at least 1 hour before drinking, stops the receptors from receiving the endorphins and hence the message that they need to survive. As the NIAA indicates, lasting changes in the brain caused by alcohol misuse perpetuate alcohol use disorder and make individuals vulnerable to relapse. So over time, the person who suffers from AUD who engages the TSM treatment has the neural pathway of them needing alcohol to survive weakened, according to the NIAAA. The frequent obsessive thoughts about alcohol and cravings for alcohol and the overwhelming feeling of needing to overdrink go away over time from alcohol use disorder. The goal of the Sinclair method, the goal of TSM is not necessarily abstinence, according to Dr. Escapa. I think we need to really understand that. The goal for TSM is left to the patient's desire for treatment goals. The goal of treatment might either be to cut back on alcohol or to abstain from alcohol. It is the patient's choice. TSM enables the patient to achieve either. Given TSM's high success rate, this modality of treatment should be taken more seriously, more readily accepted, and more readily implemented, especially when juxtaposed to the statistics that prove the failure of the goal of abstinence as the only form and widely used approach to alcohol use disorder treatment. So now I think we need to look at the consequences, right? So I've laid out the research of, what our current system is doing, how it's failing us, what the approach of our current system is, and as juxtaposed to what the science actually says in direct opposition to, I would love to play hide and seek. Can we play hide and seek in maybe 20 minutes? Can you play with Daddy right now? He doesn't want to play hide and seek. Here, come here, sit with mommy. All right, so, okay, baby, in a little bit, go get it and I'll open it for you. So an evidence-based, okay, so yes, this is where I was. I think now we need to talk about the consequences, because this isn't just a conversation. This isn't just my entire years of graduate research, presented to you. This has devastating consequences to people at large and in the child welfare system. I mean, I think it's kind of funny that my daughter just came. Okay, mommy is busy right now. Okay, came down now because, she was my first when I was turned away from receiving this life-saving treatment. And I was finally able to access it by the grace of God and the hard work of the C3 Foundation. But what if I was never able to receive it? Imagine what her life would be like today. Imagine what my life would be like today, you know? So the consequences. So alcohol is the third leading cause of death that is preventable in the United States. 18.5% of emergency department visits are related to alcohol. 28% of driving fatalities are due to alcohol impaired driving. Roughly 95,000 people die from alcohol related causes each year. About 10.5%, about 10.5% of children in the United States live with a parent who suffer from alcohol use disorder. 9.5% of pregnant women in the United States used alcohol. That's affecting the baby inside her, right? In 1996, the prevalence of fetal alcohol syndrome was estimated to be between 0.5 and 3% of cases per 1,000 in the United States. So that's at large. The consequences to children and family. Children of parents who suffer from a diagnosis of substance use disorder are at greater risk to be maltreated. And even more than just maltreatment, it leads to child fatality, and child maltreatment fatalities result from parental alcohol and substance use are carried out more on infant victims, right? Helpless infants. These children are also at greater risk, as we talked about before, for out-of-home placement and placement instability. They are also at greater risk to have subsequent child protective referrals made on them on behalf of them and their parents. And their rights of the parents are more likely to be terminated, and they're less likely to experience reunification. But take that to the table. Now I just want to quickly talk about disparities. I get chocolate off my hands. So single mothers are more affected, right? Women who suffer from substance use disorder involved with the child protective agencies find themselves in a unique position. These women experience barriers to treatment due to fear that disclosing their substance use disorder will result in a loss of custody of their children. And that was my fear. I was terrified trying to seek out that treatment that I explained earlier in the beginning, way beginning of my presentation. I was terrified and I was turned away. So it's like, why did I even try? You know, I put myself at risk, my child at risk to be removed from custody. I was already a target because I was poor back then, right? I was living in poverty. You know, homeless when she was 2 months of age, food insecure. I barely ate just so she could have her formula that she needed, right? And, you know, these women reach out and then they're punished, right? For something that's not even their fault, but the system's fault. So, and then women are forced to, if they reach out and they get caught, right, by the Child Protective Service system, right, they are forced to engage in treatment that doesn't even work. They're not even able to meet those goals. They're gonna fail, right? We have a 1% success rate, as I laid out to you in the beginning of the presentation, but they still have to be successful to get their children back. We're just setting women up for failure, right? So, and then I think we also need to talk about race as a disparity, right? A further disparity exists regarding race and ethnicity. In addition to Black mothers facing all that is listed above, Black mothers in many cases also face racism, according to Dunkerley in his 2017 paper. Black mothers are statistically more likely to raise their children on their own compared to white mothers. The single motherhood rate is 75% in the Black community and roughly 25% in the white community. Black mothers are statistically more likely to raise their children on their own. They are reported to have more abuse reports substantiated as compared to white mothers. They have their children removed and are overrepresented in the foster care system. This is just statistics I've been aware of because I'm in the field, but Hill and Dunkerley laid them out in their research. So to evaluate how women of color experience the child welfare system, we have to, really look at what we're doing here. Because Black mothers face many difficulties at at once, such as classism, racism, lack of access to needed resources, they are left with a hierarchy of decisions to prioritize and make decisions that are scrutinized by the system. And the system is often oppressive and hypercritical. So we have a major disparity here. All right, my last part of the presentation. I hope you've all stayed with me this long. I'll wrap it up in a couple minutes here. So systemic change needed to increase success rates treating substance use disorder. This is the part where there is hope, because there is hope. We can change. We just need to do the work. All right, so a need to reform the system's approach to treatment, expanding treatment options. We have many treatments for substance use disorder, not just abstain. If you don't abstain, you don't care about your life, you don't care about your kids, you don't care about your career, and it's your fault. You know, we have many different options than that. That is the 1% success rate, 99% failure rate. So with such a variety of approaches, we need to just expand the menu. I think, what is it, Dr. Jaffe says that, if I'm remembering correctly. You guys would know better probably in this audience. So listen, if a self-help group works for you, awesome, but it doesn't work for everybody. And so medication-assisted treatment works for many people, right? And so we need to just expand what we're offering to people. You know, the basic tenet of being a social worker in the code of ethics is that we let the client lead. We're supposed to let the client lead. Well, then why are social workers participating in this system that shoves one approach and only one approach down somebody's, you know, person? Why? It's going against our code of ethics, social workers. I just don't understand. And if we're supposed to have continuing education, why are we not educating ourselves in evidence-based medication-assisted treatment, such as the Sinclair method? Is it so shocking that someone who suffers from alcohol use disorder can successfully moderate drinking with the help of a medication? Is that so, you know, out of our minds? Okay. So evidence-based medication-assisted treatments, we need to expand this. Less than 4% of people who suffer from AUD are prescribed medication. That is terrible, less than 4%, but the C3 Foundation's work is improving that, right? And we need to have the client lead, because if a client doesn't, if it's not of their will or even really their decision, it's not going to be something they're going to carry out because they didn't choose it. When we force people to do things, we rarely ever see that work. It never works. And it might work for a little bit, but does it truly last? It doesn't last, right? So I have so much more research that I'm going to share here, but in consciousness of time, I'm just going to go over my very last part here. So expanding the settings where treatment is offered, the primary care setting. We need to educate primary care providers. It is so easy. Primary care providers, you just need to prescribe the naltrexone, get the continuing education, reach out to RIA Health. Maybe RIA Health can come up with some program to educate, you know, the medical community or something. We need to work with medical schools to educate primary care physicians. Listen, you can prescribe this medication. This is how it works. And okay, fine. If you're scared, if it gets out of hand, as my primary care provider who knew nothing about TSM, but she was willing to learn. She said, I am going to do it because if I'm of the mind that if it's what is that phrase? If it's broke, it doesn't need to be fixed or something. Like basically, if it's working, let's keep doing it. She's like, but if it ever becomes a problem again, I would feel more comfortable with you going back to RIA Health. And, you know, so that's what we can do, right? And then other alternate settings. You know, there are other medical settings that can prescribe this medication. This is such an easy thing, and it works for such a large amount of people, right? All the clinical trials demonstrated a 78% success rate with a 10 or 11% non-medication compliant rate. So if this has a 88 to upward 88 to 89% success rate, I would argue if people were medication compliant, we have a possibility to getting to that statistic, then why are we not doing this? Okay, if it doesn't work for the other 11%, we have Work It Health to reach out to. We have RIA Health to reach out to. We have experts in the field. But let's get the most amount of people treated, because behind them is probably children who are suffering and who need their parents back. Yes, thank you. And that was basically the end of my presentation.
Okay, I'm gonna go ahead and go ahead and unshare your screen for a second.
Okay.
And go ahead and put myself back on here. Oh. Let's see. I've still got your screen.
Oh, I'm sorry. I'm a millennial, but I need to be more technologically savvy here. Let's see. Oh, you're screen sharing. No. Stop video. Is it stop? No, it's not stop video. Pause share. Oh no. Okay, stop share.
Okay, there we go. Okay, so I do want to just thank you before we run off. We are full time here, so we need to move on into our next intermission so I can get set up for the next panel. But lovely having you talk today. The audience loved the way you multitasked as a mom and a presenter during during your presentation. And then I would just ask that if you wouldn't mind, send all your links and research so that when I post the video up for replay on our website, I can add the reference links in. And thank you so much for being here today and discussing this really important topic.
Yes, definitely. Thank you so much. I'm sorry I didn't have time for Q&A. I guess I need to get my presentation a little bit shorter.
It's
my first time. So
perfectly fine.
Thank you.
You did wonderful. All right. Thank you so much.
All right. Take care.